Mac na connector. Tapos hindi siya gumana. So gumana siya dito sa...
Pusang mo na lang.
Excited pa naman akong gamit. Anyway. So, okay, good morning. Today we'll be discussing intrapartum fetal assessment. So I hope you remembered yung antepartum fetal assessment, di ba? Inaral nyo na yun kasi nag-exam na kayo noon. Kumusta yung exam? Dali na ba? Madaling bumagsak. Okay, so for the intrapartum fetal assessment, actually we'll be focusing on one modality, which is your cardiotochogram. Kasi yun naman yung clinically mas ginagamit when you rotate sa JPL or sa AUF. Okay? So, again, these are the references. So, the main difference between your antepartum and your intrapartum fetal monitoring is the presence of your uterine contractions. Okay? So, remember yung non-stress test ninyo. Okay? So, it's the same except there's presence of your uterine contractions already. So, what happens during labor? Okay? So, what happens during contractions is that there is of course, when there's uterine contraction, so there will be decrease in the fetal to maternal circulation. Okay? So, what happens is that the vessels now running into the myometrium are decreased because of the uterine contraction. But of course, there should be a physiologic response ng baby. Okay? Kasi diba anticipated naman niya na merong uterine contractions. Okay? So other than the uterine contractions, it could also be it's also a factor yung position of the placenta, no? Kung may cord coil siya, because as the uterus contracts, the umbilicus, your umbilicus such as your umbilical artery and your umbilical veins are also compressed, no? Especially if yung location ng umbilicus is along the parang fetal head or the fetal buttock, so mas matindi yung compression. Okay? So, what is the physiologic response of the baby during uterine contractions? What do you think happens? How does it compensate for the transient decrease in maternal fetal perfusion? What will happen? So, there is slowing of the fetal heart rate. Di ba yun yung unang response sa stress? Di ba magkakaroon ng decreased fetal activity, which is your fetal heart rate. Remember? Di ba yung NST nyo yung naunang nawawala? But, syempre dito hindi na siya NST because there is contraction. Okay? So, there will be slowing of your fetal heart rate, and then, syempre yung uterine contraction nyo kasi di ba nagpipeak yan? So it's hyperbolic, so nagpipeak siya. So during the peak of your uterine contractions, merong mga baroreceptors, no, sa umbilicus that would signal, no, ano mangyayari? There will be, what happens? So there will be decrease in the fetal heart rate, and what happens? There will be a release of your adrenaline. Okay, so what happens when there's release of adrenaline? There will be decreased perfusion to the peripheral vessels, and there will be increased perfusion to the central organs such as your brain, the heart, no, and the lungs. Okay, so until the next uterine relaxation. Okay? That's why it's very, very important when you do your labor watch to make sure that there is enough time between uterine contractions and uterine relaxation, because the baby needs the uterine relaxation to recover from the transient hypoxia brought about by the uterine contractions. Okay? So remember that. Okay, so definition of your tachography, the technique of recording the fetal heart rate and the uterine contraction. So laging in association with the uterine contractions with the use of your cardiotachograph, also known as your electronic fetal monitoring. Actually, for your CTG, hindi siya masyadong well-studied. No? So the goal is to prevent fetal loss. However, there's actually no good studies regarding the efficacy of CTG versus non-use of CTG, or versus CTG and the use of your fetal auscultation alone. Okay? But however, it's so ingrained in our practice right now that it's hard to do a randomized controlled trial anymore. No? Parang hindi na acceptable not to do electronic fetal monitoring if it's available in your institution. Okay? So medyo mahirap nang gumawa. But you can make a cohort study if you want. Pero medyo mahirap na mag-RCTs because walang obstetrician na hindi ayaw mag-electronic fetal monitoring. Kasi parang ano namin yan, blanket of protection natin for peace of mind. Okay? Okay, so how do you do your electronic fetal monitoring? Kasi yun yung magiging job nyo as clerks. Pag may dumating na buntis, so iupo mo yan sa CTG. Okay? So, you have to position the mother in the lateral recumbent or half-sitting or upright position. Okay? Hindi pwedeng supine position kasi it may result to aortocaval compression, decreasing fetal oxygenation. Okay? So, laging ganyan. Kasi minsan, ang pagkakamali ng mga clerks and residents, no, nakasupine and then pangit yung trays and then sa kanila i-resuscitate. So, dapat initially pa lang, nasa tamang position na si mommy. Okay? So, who are the candidates for fetal heart rate monitoring? Meron ba tayong patient na pwedeng i-exclude from fetal heart rate monitoring? So, all viable pregnancies are candidates for fetal heart rate monitoring. Okay? Not unless, kunwari, meron kang threatened miscarriage, no? Hindi mo naman yun fetal heart rate monitoring kahit naman magkaroon ng abnormalities in the fetal heart rate pattern, we will not intervene by either doing cesarean section or expediting the delivery. So any viable pregnancy are candidates for fetal heart rate monitoring because any abnormality would prompt intervention, okay? Either an abdominal delivery or expediting spontaneous vaginal delivery. Okay. So, intermittent versus continuous monitoring, ano yung usually ginagamit natin? Okay, so for low or average risk pregnancy, you can use intermittent monitoring using a Doppler device or a fetal stethoscope. Nakakita naman na kayo, no, ng Doppler device, yung parang maliit na ultrasound, and then there's a small gadget, tapos maririnig mo yung fetal heart tones. Okay? Now, may mga bago na ganun na parang makikita mo na din yung parang may trace na din siyang makikita. And then you can print the tracing. But, yeah, during our time, it's a luxury to have that kasi mahal yung dati. So, pag meron ka na nasa student, mayaman ka. Okay? Parang yung pulse oximeter dati nung clerks and interns kami, sign of, yaman. Ngayon kasi parang medyo, di ba? It's basic. Sa amin dati, pag may ganun ka, mayaman ka. Anyway, so ECHO guidance stated that either continuous electronic fetal heart rate monitoring or intermittent auscultation is acceptable in uncomplicated patients. So, usually mga OB normal. Okay? But for high-risk pregnancies, they should be monitored continuously during labor. So, patients with preeclampsia or GDM na insulin requiring, better to monitor them continuously. Okay? Okay, so what happens here is that oxygen transfer from the environment to the fetus represents the first component of your fetal oxygenation, okay? And the second component, okay, so yung second component of fetal oxygenation involves the fetal physiologic response to interrupted oxygen transfer, yun nga yung during the contraction, okay? So, there is recurrent or sustained hypoxemia can lead to decreased delivery of oxygen to the tissues, leading to compromised cell function and eventual cell death and organ damage. So the cascade begins with hypoxemia, and then which is defined as the decreased oxygen supply to the tissue, And when oxygen is in short supply, tissues may be forced to convert to aerobic to anaerobic metabolism, now making energy generation less efficient and resulting to the production of lactic acid. Okay, so the accumulation of this acid causes metabolic acidosis, and this will eventually lead to your cellular cell death or organ damage. So clinically, this is translated in possible fetal death in utero or neonatal neurologic outcome of your ischemic encephalopathy or possibly cerebral palsy. Okay, so eventually it could lead also to death. Okay, so how do we choose? No, ano yung gagamitin natin for your for monitoring your fetal heart rate pattern? So you can use your external electronic monitoring, which is the more common. You can also use intermittent auscultation, and you can also use your internal electronic monitoring. Okay, so your external electronic monitoring can be performed continuously or for variable periods of time with a Doppler ultrasound device on the maternal abdomen. Ito yung CTG. Okay? Nung students kami, we only use intermittent auscultation. So, ideally, you use a fetal stethoscope or a fetoscope. Nakakita na kayo ng fetal stethoscope? Wala na, no? Archival na kasi siya. So, it's a stethoscope with a bell. No? So, may bell siya. So, actually, para siyang yung bell nung stethoscope niyo. Di ba? But yun, pure bell lang siya. So, parang ganon. Mukha siyang cylinder, pero you can use your normal stethoscope. It's okay. Okay? So and then you use it intermittently during labor. So you auscultate immediately after the end of a contraction. Okay? And then we can also use your internal electric monitoring, or it's a fetal ECG that can be obtained by placing a bipolar spiral electrode into the fetal scalp, and then a computer calculates the fetal heart rate based on yung RR interval nung fetal heart rate ng baby. Okay? It's not available here, yung internal electronic monitoring, but it is available in other institutions such as St. Luke's Global, ganyan, but not available in AUF and in JBL. Okay? So how do we frequently monitor? Okay, so for your external electronic monitoring, you can do your labor admission test. Historically, we always do the labor admission test, but this is not necessary anymore. Okay, so upon admission to the labor unit, the standard of care in most hospitals is to assess the fetal heart rate for a minimum of 20 to 30 minutes. Okay, so for low risk, you can monitor the fetal heart rate at least every 30 minutes in the active phase of the first stage of labor, and at least every 15 minutes in the second stage. Okay, so mas madalas na siya once the patient is in the second stage of labor. What is the second stage of labor? From
labor to delivery.
From
Labor to delivery.
labor to delivery. Ang first, sige, what is the first stage? From where? What is the From 6 cms, meaning active phase of labor, 6 cms, which is 6 cms now, before it's 4 cms, diba? Until full cervical dilatation. And your second stage would be from full cervical dilatation up to delivery of the baby. Okay? So, during the active phase, every 30 minutes, and during the second stage of labor, every 15 minutes. Okay? For high-risk patients, again, you should monitor the fetal heart rate continuously. Okay? Or, kung walang continuous monitoring, you can intermittently auscultate every 15 minutes in the active phase of labor and every 5 minutes in the second stage. So, mas madalas mag-monitor kapag high risk. Okay? For intermittent auscultation, you can also do, listen to the fetal heart rate for 60 seconds and record the rate during and immediately after a uterine contraction at least every 30 minutes during the active phase of first stage of labor, and at least every 15 minutes during the second stage. So for high risk, again, it's mas madalas, So every 15 minutes during the active phase of the first stage of labor, and at least every 5 minutes during the second stage. So it's important that you also auscultate during A contractions for you to be able to appreciate possible changes in the fetal heart rate, especially kung magkakaroon ng decelerations. Okay, so the assessment of your uterine activity is very, very important as well because you have to correlate, no, kung saan nagkakaroon ng changes in the fetal heart rate. Whether it happens during the early stage of the contractions, during the middle of the nadir of the contractions, or after the contraction. Okay? So the interpretation of your fetal heart rate tracing is dependent on the uterine activity as well, and also the management. Okay? So for your fetal heart rate characteristics, you should know these four components. No? Your baseline fetal heart rate, the variability, the acceleration, and the decelerations. Okay. So nowadays, actually, medyo confusing because you have to study two guidelines, no? The National Institute for Child Health and Maternal Health, and also FIGO. Okay, so dalawa sila, medyo magkaiba ng konti. Okay, so we have to study that. Okay, so for your baseline fetal heart rate, according to NICHD, it is the mean fetal heart rate rounded to increments of 5 beats per minute during a 10-minute segment, no? Excluding periodic or episodic changes, periods of marked fetal heart rate variability, segments of baseline that differ by more than 25 beats per minute, and baseline must be identifiable in at least 2 minutes. So that's your baseline fetal heart rate. For FIGO, medyo mas madali siyang intindihin, no? It's the mean level of the most horizontal and less oscillatory fetal heart rate segments, estimated in 10-minute periods expressed in beats per minute. Okay? So actually, pareho lang naman sila. So your baseline fetal heart rate, normally it's around 110 to 160 beats per minute. So that's your normal. Okay? Tachycardic, if it's more than 160 beats per minute. But for FIGO, nag-include lang sila ng time component if it's more than 10 minutes. And for bradycardia, it's less than 110 beats per minute. Okay? So yan. So pag tinignan nyo tong tracing na to, so you can see here, no? So, titignan nyo kung asaan yung pinaka mean na baseline fetal heart rate. Okay? So, kung nasaan yung, according to FIGO, the most flat, no, less oscillatory area of your fetal heart rate tracing. So, ano dyan ang baseline fetal heart rate? What is the baseline fetal heart rate for this tracing? So this is, di ba, 120, 130, 140, 150. So first, is it normal or abnormal? Normal. It's within 110 and 160. And so what is the baseline fetal heart rate? So it's 132. It's a range, di ba? Laging it's a range. So it's 132, 135. Di ba? 5 beats increment lang siya. So 132, 135. That's your baseline fetal heart rate. Okay? So a normal baseline fetal heart rate, as mentioned earlier, is 110 to 160 beats per minute, and it reflects lack of pathology related to factors that regulates your fetal heart rate. So what are these factors? What are the factors that regulates your fetal heart rate? Of course, number one would be your intrinsic cardiac pacemakers, your cardiac conduction pathways. What else? Autonomic innervations such as your sympathetic and parasympathetic innervations. And then you have your intrinsic humoral factors such as your catecholamines, and of course your extrinsic factors and local factors such as your calcium and potassium. Okay, so yun yung nag-a-affect no baseline fetal heart rate. Okay, so this one, your baseline is 132, 135 beats per minute. So for this tracing, so this is abnormal because of fetal tachycardia. Okay? So what is usually related with fetal tachycardia? Maternal. Okay, fever. So possible infections. What else? Especially if you have prolonged rupture of bag of waters already, so you can suspect beginning intraamniotic infection. Okay, what else? So fever, infection, either infection of the maternal infection or fetal infection. What else? Arrhythmia. Okay, pwedeng because of arrhythmia, fetal arrhythmia. What else? Medications, no, given during labor. What else? Ano yung mga maternal condition that could cause fetal tachycardia? Hyperthyroidism, yeah, correct. Hyperthyroidism. What else? If there's elevated catecholamines, and yun nga, if there is interruption of fetal oxygenation. Okay, so that's when you see tachycardia. How about bradycardia? So you can see here that the fetal heart rate dips, no? Ilang beats per minute below the baseline from 135 to 140, bumagsak siya ng 60s. Okay, so what usually causes fetal bradycardia? Okay, hypoxia, of course. What else? Oh, cord compression will lead to hypoxia eventually. Okay, what else? Placental abruption will also lead to fetal lack of oxygen, no? Decreased fetal oxygenation. What else? Ano yung usually binibigay sa mother kapag nagpo-preterm labor? No? Mga beta blockers can cause bradycardia, di ba? What else? What could cause bradycardia? Can hypothermia cause bradycardia? Yes. Okay, what else? Kailan pa? Kailan ano yung baby? Kailan magiging bradycardia? Kapag medyo lack of energy, no? Which could be because of hypoglycemia, can cause bradycardia as well. Kabaliktaran ng hyperthyroidism, you can have your hypothyroidism. Okay? Or if there is fetal heart block, okay, could cause bradycardia. Okay? So yan, bradycardia siya at 60 beats per minute. Okay? Now that you know your fetal heart rate, baseline fetal heart rate, malalaman na natin kung meron ba siyang good variability, if there is acceleration and deceleration. No? So it's very important to establish your baseline fetal heart rate because you need that information for you to be able to recognize accelerations, decelerations, and variability. Okay? So what is variability? No? It's the fluctuations in the baseline fetal heart rate that are irregular in amplitude and frequency. So they are usually visually quantified as the amplitude of peak to throw in beats per minute and determined in a 10-minute window and excludes your accelerations and decelerations. Okay? So for FIGO, hindi ko alam kung bakit ang haba ng definition ng NICHDF. Ang FIGO, it's defined as average bandwidth amplitude in 1 minute segment. Okay? So, kung ano nang makikita mo, so, variability is actually described as yung amplitude lang yung ng baseline fetal heart rate mo. Okay? So, either it's 20, 15, 22 to 18, but the average variability is usually 20 beats. No? 20 beats. So, what does your variability tells you? Anong ibig sabihin ng, kasi gusto natin, ideally, is to have a moderate variability, no? Or normal variability. What does it tells you? So, It actually reflects adequate oxygenation of the central nervous system and reliably predicts the absence of damaging degrees of hypoxia-induced metabolic acidemia at the time it is observed. No? So it's a reassuring fetal heart rate pattern if you have moderate variability. Okay? So we can classify variability as such. So for NICHD, could be absent, minimal, moderate, and marked. For FIGO, tatlo lang, it's normal. Either it's reduced or increased. Okay? So for your NICHD, absent variability is usually described as undetectable amplitude range. Yan. Kita nyo? So wala, no? Kita nyo para siyang flat line. So that is absent variability. For minimal variability, if it's undetectable to less than 5 beats per minute, okay, so hindi siya flat pero parang tinamad, no? Tinamad yung baby na mag-trace. For for moderate variability, that's what we want. So it's usually 6 to 25 beats per minute variability. So ito yung gusto nating variability. Okay? But for marked variability, ayan, so this is not good as well, no? Yung marked variability. So you can see here that it's more than 25 beats per minute. Yung minute-to-minute fluctuations ng baseline fetal heart rate. Okay? So for your FIGO, okay, so you have 3 classification. Normal is when you have 5 to 25 beats per minute variability. Reduce if there is less than 5 beats per minute for more than 50 minutes in baseline or more than 3 minutes in decelerations. And increase or saltatory if there is the bandwidth is greater than 25 beats per minute for more than 30 minutes. Okay? So actually minsan eyeballing lang naman, no, clinically. Wala naman katulad sa ECG na yung meron ba kayo gano'n? Yung i-measure mo yung caliper, no? So sa tracing naman, it's usually eyeballing, no? So it's very subjective. So yun yung medyo limitation ng your intrapartum monitoring. It's very subjective, so sometimes nag-iba-iba yung interpretation even for maternal fetal experts. Okay, so now we move on to the acceleration. Okay, so wait lang. So anong ibig sabihin pala kapag meron kang marked variability? So kasi alam natin if there's decreased variability, then possibly, di ba, the explanation is that there is fetal acidemia, and then yun nga, it affects your CNS, no, yung fetal CNS. That's why decrease yung variability niya. And also, yun nga, kapag may acidemia, nagko-conserve ng energy si baby, no? Kaya hindi makita yung variability ng fetal heart rate. But for marked variability, ano ibig sabihin nun? If there's marked variability, mas masaya ba si baby? No? Mas maligalig ba siya? Mas energetic ba siya? Kasi marked yung variability niya. What is the clinical significance of a marked variability? Actually, the significance of marked variability is unclear. No? So it may be a normal variant or it may be an exaggerated autonomic response to transient or sustained interruption of fetal oxygenation. Okay? So it has been observed in early stages of intrapartum fetal hypoxemia and before birth in some acidotic newborn. So it could also be a sign of fetal acidemia, but yun nga, hindi siya well established as opposed to your decreased fetal variability. Okay, so maybe you can study, no, this outcome of patients with marked variability. So pwede yung study kung ano ba talaga yung effect niya sa fetal outcome. Okay? Okay, now we move on to your acceleration. So from the root word acceleration, no, it's an abrupt increase in your fetal heart rate. No? So the onset to peak is usually less than 30 seconds and it should be greater than 15 beats per minute lasting for 15 seconds from onset to return to baseline. No? Same as your NST, di ba? 15 beats per minute for 32 weeks and above, but for lesser than 32 weeks, pwede kang mag 10 beats per minute lasting for 10 seconds. Okay? So the same as with your FIGO. Okay, now you have your deceleration. Okay, so the quantification of your deceleration magnitude is based on the depth of the deceleration's nadir in beats per minute below the baseline, excluding any transient spike or electronic artifact. Okay? So the duration of the deceleration is quantified from the start of the deceleration to the end of the deceleration. Okay? So it's labeled as recurrent or repetitive if it's more than or greater than 50% of the uterine contractions in any 20-minute segment. Okay? So your decelerations are further subdivided into early, variable, and late decelerations. Okay? So for your early decelerations, it's usually a gradual decrease and return to baseline of the fetal heart rate associated with a uterine contraction. So the nadir of your fetal heart rate and the peak of the contraction occurs at the same time. Okay? Naintindihan yun? Sige, mamaya tingnan natin. For FIGO, no, it's a shallow, short-lasting with normal variability and coincident with contraction. So medyo mas vague yung description ng FIGO. So for your early deceleration, okay, so ang ano natin is the lowest fetal heart rate coincides with the peak of the contractions. Okay, so yun lang yung kailangan yung tandaan sa early decelerations. Okay? That the lowest fetal heart rate coincides with the peak of the uterine contraction and then it recovers after. Okay? So there's an abrupt drop and then drop until the peak of the uterine contraction and then the recovery after the uterine contractions. Okay? So that's your early deceleration. Okay? So it's usually is associated with your fetal head compression during labor and are generally considered benign and inconsensual. Okay, so if you see early decelerations, especially during the second stage of labor already, kasi di ba, yung ulo nandyan na. So naiipit talaga siya. So wag kang matakot, no, because it's inconsensual. Okay? And it's not normally associated with fetal acidemia. Okay. So now we move on to variable deceleration. Medyo mas vague yung variable deceleration. So there's abrupt decrease in the fetal heart rate with the onset of the deceleration to nadir of less than 30 seconds. No? So the deceleration should be at least 15 beats below the baseline, lasting for at least 15 seconds but less than 2 minutes in duration. Okay, so why is it important na merong ganitong description, no? Your deceleration should be less than 15 beats below the baseline, should be at least 15 beats below the baseline, lasting for 15 seconds, not lasting for more than 2 minutes. So why is it important to categorize na dapat less than 2 minutes lang yung deceleration? Because if it's more than 2 minutes, if it's more than 2 minutes, that's fetal bradycardia already. No? Hindi na siya part ng normal decelerations ng baby. Okay? So if it's more than 2 minutes, that's fetal bradycardia. Ibig sabihin, sobrang compromise na ng baby because of the decreased oxygenation and possible fetal acidemia. Okay? So for FIGO, no, it's defined as a rapid drop, rapid recovery, and good variability. So tingnan mo, no, si FIGO lagi niya sinasabi na there should always good variability, okay, for your deceleration. So it's usually varying in size, shape, and relation to uterine contractions. So ito yung keyword, no? So nagbabari siya sa size, shape, and relation to uterine contractions as opposed to your early deceleration that it happens during the nadir of the contraction. So for your variable decelerations, nagbabago-bago yung peak ng deceleration niya sa uterine contraction. That's why it's variable. Okay? So usually, if your early deceleration is associated with your head compression, so your variable deceleration is usually associated with your cord compression. Very good. Okay, so what happens is that yung baroreceptor mediated response to increase in BP during cord compression, would yun nga, release your adrenaline, and then your catecholamines, and then nagkakaroon ng deceleration and eventually recovery. Okay, so majority of your deceleration actually that you will see in the clinics would be because of your variable decelerations. Okay. So next we have your late deceleration. This is more important. No? So there's a gradual decrease and return to the baseline fetal heart rate in association with, again, uterine contraction with the time from onset of the deceleration to its nadir as 30 seconds or longer. So the deceleration's timing is delayed with the nadir of the deceleration occurring after the peak of your uterine contractions. That's why it's late, because the deceleration happens later on during the contractions. Okay? So onset is usually 20 seconds after the start of the contractions and nadir after, and return to the baseline after the end. Okay, so you can see here, so magkakaroon ka lang ng abrupt decrease in your fetal heart rate after the contraction already, no? And then the drop happens, no? Kahit na tapos na yung uterine contractions mo. So that is your late deceleration. So what does it tell you kapag meron kang late deceleration? There is already utero-placental insufficiency and implies some degree of hypoxia already. Kasi nga, dapat, okay na si baby, di ba, after contractions, dapat nag-return na yung normal feto-maternal circulation. But during late decelerations, it could be because of your utero-placental insufficiency. Okay? And then you also have your sinusoidal pattern. Di ba, na-discuss na natin yun. No? So pwede din magkaroon ng sinusoidal pattern. Again, it's regular, smooth, undulating, resembling a sine wave. No? The amplitude is usually 5 to 15 beats per minute. The frequency is 3 to 5 cycles per minute, lasting for 30 minutes with no accelerations. And then your pre-sinusoidal pattern, you have your jagged tooth appearance. Duration seldom exceeds 30 minutes. Normal patterns before and after the pre-sinusoidal pattern. Okay? Okay, now let's move on to the interpretation. Okay, so for your NICHD, the three-tier interpretation system is categorized into a category 1, category 2, and a category 3, as opposed to your FIGO classification wherein it's classified as normal, suspicious, and pathologic. Okay? So for your category 1, so yan yung gusto natin, no? Category 1. So the baseline fetal heart rate is usually normal, 110 to 160 beats per minute. You want a moderate variability. Accelerations could be present or absent. No, mas importante ang variability than accelerations. Decelerations, ang pwede lang is your early deceleration, especially during the second stage of labor. Okay? So for your category 2, so you can have your bradycardia not accompanied by absent variability. You can also have your tachycardia if there is minimal variability, if there is absent variability not accompanied by recurrent decelerations, or if you have marked variability. Kasi your minimal and absent and marked variability are signs of possible fetal acidemia. Okay? So acceleration, there should be absence of induced accelerations after fetal stimulation. So kung kunwari, walang acceleration and then you stimulated the fetal scalp already and then wala pa din siyang acceleration, then you can categorize the tracing as category 2. If there's recurrent variable decelerations accompanied by minimal or moderate baseline variability and variable decelerations with other characteristics such as slow return to baseline, overshoots, or shoulders. You can also have category 2 if you have recurrent late decelerations with moderate baseline variability. No? So, pwede pa rin magkaroon ng late decelerations but maganda pa rin yung variability. Okay? So, if there's prolonged deceleration greater than or equal to 2 minutes but not more than 10 minutes. Because if it's more than 10 minutes, then that's a change in fetal heart rate baseline already. So you have your category 3 if there is absent baseline variability and any of the following. So you can see here, no, NICHD puts a premium on variability. Okay? As long as you have good variability, even if you have decelerations, medyo okay ka pa, no? Category 2. But if there is absent baseline variability, then nasa category 3 ka na. If there is recurrent late decelerations, if there's recurrent variable decelerations, or if there's bradycardia, so you're category 3 already. So for your FIGO classifications, so medyo mas madali siyang intindihin, no? So for normal, you have a normal baseline, you have a moderate variability, you have no repetitive decelerations, so the interpretation is category 1, no hypoxia or no acidosis, so you don't have to do any intervention. For suspicious, no, there is lacking at least one characteristics of normality, but with no pathologic features. Okay, so suspicious if there is decreased variability or if there is increased variability, no? If there is, what else? Kung ano pa yung mga magiging suspicious. If there is tachycardia, bradycardia, no? So, suspicious siya. Pathologic if there is bradycardia of less than 100 beats per minute, if there is reduced variability, increased variability and sinusoidal pattern, if there's repetitive late or prolonged deceleration for greater than 30 minutes or greater than 20 minutes if there is reduced variability, and if there is deceleration for more than 5 minutes, no? So, the action is immediate action to correct or reversible to correct reversible causes, adjunctive methods, or if possible, expedite delivery. So, what difference can you see in terms of when you use your NICHD and when you use your FIGO classification? What is the clinical implications? Medyo mas, which is more conservative? Your NICHD or your FIGO classification? Which do you think would result more to a cesarean delivery? If you use your NICHD or if you use your FIGO classification? FIGO, no? So FIGO is more, NICHD is more conservative. No, kung makikita mo, di ba, parang yung mga nasa category 2, pathologic na sa FIGO. Okay? So mas mababa yung threshold for expediting delivery, which is most common is abdominal delivery. Okay? So mas mababa yung threshold niya. So ito yung problem with FIGO classification nowadays actually is that there is increase in your cesarean section rate because it has a lower threshold for expediting delivery. Okay? As opposed to your NICHD. The drawback of your NICHD is that medyo magulo siya. Hirap siyang clinically. Di ba parang hindi mo ma-memorize, kailangan mo ng código before. So it's easier, yung FIGO classification is easier to use, but yun nga, yung threshold niya for expediting delivery is lower than your NICHD. Okay? But what our society actually promotes is the usage of your FIGO classification. Okay? So again, what happens during labor? So uterine contraction transiently decreases fetal oxygenation by compressing on the blood supply of the placenta. The normal fetus should tolerate the transient oxygen depletion due to uterine contractions, but abnormal fetus has inadequate oxygen reserves and cannot tolerate uterine contractions. Okay? So how do we manage? patients with, depending on the category of their traces. Okay, so for your category 1 trace, that's normal, correct? So you allow the patient to ambulate, to bathe, or choose more comfortable position. So there should be no intervention necessary. And then you have to continue monitoring as mentioned earlier. So for low rates, every 30 minutes during the first stage of labor and every 15 minutes in the second stage. For high-risk patients, every 15 minutes in the first stage of labor and every 5 minutes during the second stage. Okay? That is why kapag nasa clinics kayo na, pag nag-duty na kayo, dapat ang position nyo, fetal, stethoscope, tapos yung isang kamay nyo nakapatong sa maternal abdomen to monitor your contractions. Okay? So yun lagi. So wag kayong mapapahuli sa mga residente nyo na walang ginagawa. So dapat laging nakapatong yung kamay nyo kahit natulog na kayo. Okay? So sobrang takot namin dati sa mga OB residents namin kasi masusungit ang OB residents sa PGH. One time, basta pag bumaba yung resident, dapat may ginagawa ka. Either nag-accomplish ka. Dati nag-accomplish kami ng mga dami-dami paperwork sa atin, di ba? Di ba computer, so mga meeting blah 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 blah, tapos nakaganon ka ba. So dahil sa takot namin dati minsan, kahit ectopic pregnancy, pag bumaba na sila, na routinely napapaganon ka kahit na yung binabantayan mo ay ectopic pregnancy. Anyway, so yun. So bawal kasing walang ginagawa dati. Okay? So for high-risk patients, 15 minutes, no? First stage of labor, and then every 5 minutes during the second stage of labor. Okay, so for your category 2 trace, so you have to evaluate for factors that may reduce fetal oxygenation, taking into account associated clinical circumstances, and the stage and the progress of labor. Okay, so resuscitative measures can be initiated if you have a category 2 trace, and of course continued surveillance and frequent reassessment. For category 3 traces, very naman yan, outright, so you have to expedite delivery. So the route is depending on the stage of labor. If fully naman na siya, then maybe you can do forceps extractions or vacuum extraction. But if malayo pa siya pagiging fully, then you can do your abdominal delivery. Okay? So how do you resuscitate? So you reposition, no, bawal ang supine position. And then you have to administer oxygen, administer IV fluid bolus. You have to discontinue uterotonic drugs. You can administer your tocolytic. You can do your amnio infusion, or you can consider other ancillary tests which we'll discuss later on. So how do you reposition the patient? You put the patient onto her left or right side to relieve cord compression and or improve uteroplacental perfusion. Okay, so you can also try a knee chest or all-fours position to relieve a possible cord compression, especially kung fully dilated na yung pasyente. Okay? You can also administer oxygen, no? 8 to 10 liters per minute of oxygen via a non-breather mask or your face mask. You can administer IV fluid bolus of 500 to 1,000 ml of lactated Bingers or normal saline solution, given that your patient don't have the risk factor for congestion. Okay, so you have to be, of course, careful kapag you're dealing with gravidocardiac patients. Okay, so giving your IV fluid bolus can improve placental blood flow and fetal oxygenation if the patient is hypovolemic, usually from prolonged lack of oral or intravenous intake, or sometimes vomiting or sympathetic blockade. Okay, so very common yan sa mga, kasi usually pinapag-NPO, no? Although it's not advised, kapag first stage of labor na, yung mga pasyente natin sa labor room, historically, in-NPO na sila. So, yun yung usual cause ng mga variable decelerations mo, no? Because of decreased oral fluid intake. Okay? So you can also discontinue your uterotonic drugs, especially if your abnormal fetal heart rate patterns comes in early on during your during labor. Okay? Or especially if you are giving oxytocin, if you're inducing the patient, or if you're augmenting the labor, then you can discontinue your uterotonic drugs. Or you can also give your tocolytics. Usually we give terbutaline 250 micrograms subcutaneously. Okay, so you can give that as well. For some, they do amnio infusion, especially for variable decelerations. No? So the only indications of doing amnio infusion is if you have variable decelerations, persistent variable decelerations. So how do you do that? So there's you can infuse a bolus amount, so around 250 to 600 ml of your lactated renal solution without dextrose given over 30 to 60 minutes, and then continuous infusion rate of 200 ml per hour. No? So your end point, you want vaginal delivery to be achieved. However, safety concern is encountered, especially for meconium stained baby already. No? So minsan, ayaw nating nagbibigay ng amnio infusion kapag meconium stained na si baby. And yung lack of knowledge actually of doing amnio infusion. Not all obstetrician is parang comfortable in doing amnio infusion. Okay, so most of the time, nagkakaroon na ng mga persistent variable decelerations, obstetrician would opt to do cesarean section than doing the amnio infusion. So what do you do is, meron dapat tayong amnio infusion na but wala tayo niyan dito. So what we do is, we insert a, alam niyo yung, what do you call that, the feeding tube? Nakakita na kayo ng feeding tube. So yung feeding tube, ini-insert siya, no? Dun sa, syempre dapat ruptured bow na, okay? So ini-insert siya sa posterior ng head ng baby, and then mag-infuse ka lang, bolus, and then kapag nag-improve, then you can maintain the amnio infusion. So ang dyan kasi is that during labor, kapag konti na yung amniotic fluid mo, mas what do you call that? Mas na-aggravate yung impact ng uterine contractions kasi wala nang magbabuffer na amniotic fluid. Okay? So that's the parang rationale of doing amnio infusion, para at least hindi masyadong nako-compress yung baby during uterine contraction. Okay? So yun nga, but hindi masyadong ginagawa because hindi masyadong comfortable yung mga obstetrician doing amnio infusion. Okay? So other ancillary tests, you can do your scalp stimulation, your scalp pH determination, fetal ECG, or fetal pulse oximetry. Okay? Okay, nakita nyo na yan. Okay, so what do we do for so mas detailed, no? Detailed management of your category 1 traces, for your category 2 traces, if there is intermittent variable decelerations, it's a common finding usually associated with normal outcome, so no intervention required. For recurrent variable decelerations, more than 50% of the contractions, it could be umbilical cord compression, it could be associated with impending acidemia, especially if progress increase in depth, duration and frequency. Moderate variability and or acceleration suggests fetus is not currently acidemic. No? So what you do, reposition the mother to left or right lateral. You can do your amnio infusion, no, for recurrent variable decelerations, and adjunctive measures to promote fetal oxygenation. Okay? Delivery is indicated if tracing does not improve and acidemia is suspected. Okay? For recurrent late deceleration, it could be a sign of transient or chronic uteroplacental insufficiency, such as from hypotension, tachysystole, or maternal hypoxia. Accelerations and or moderate variability suggest fetus is not currently acidemic. So you can reposition the mother to left or right lateral position. Adjunctive measures can be done to promote fetal oxygenation as well. But delivery is indicated if after resuscitative measure, tracing is not improved. Okay? So for patients with fetal tachycardia, it could be again due to infection, medication, maternal medical disorders, or obstetric complications, or fetal tachyarrhythmia. So you have to treat underlying cause if known, and you can initiate scalp stimulation to provoke fetal heart rate acceleration, which is a sign that the fetus is not acidotic. Okay? So delivery is indicated if tracing again does not improve and acidemia is suspected. For fetal bradycardia, okay, so acute onset may be due to hypotension, umbilical cord occlusion, rapid fetal descent, tachysystole, abruption, or uterine rupture. And what you do is you treat underlying cause if known. So you can again initiate scalp stimulation to provoke fetal heart rate acceleration. Okay? For minimal variability, could be the fetus is asleep. It could be also due to medication, especially if you give magnesium sulfate to mommy. No, we usually sedate kasi the mother when we give magnesium sulfate for hypertensive disorders. So your sedation to the mommy can also sedate the baby. So expected to have minimal variability after administration of your magnesium sulfate. Okay? So if there's decreased fetal oxygenation, if you are suspecting that, then you have to reposition the mother to either the left or right lateral, and then you can give your adjunctive measures to promote fetal oxygenation. If again there's no improvement and no accelerations, then you can stimulate the head. Okay, for tachysystole, so pwedeng because of spontaneous labor, di ba? Okay, or tachysystole may be associated with fetal acidemia if accompanied by your recurrent fetal heart rate decelerations. So management again is repositioning of the mother, oxygen supplementation, IV fluid, bolus. If ineffective, then reduce your uterine contractions frequency with a tocolytic. Okay, you can also initiate scalp stimulation to provoke fetal heart rate acceleration. So during induction or augmentation, it could also result to your tachysystole. So what you do is you decrease or you stop your uterotonics medications. Okay, so for your category 3, if there is absent baseline variability and recurrent late decelerations or recurrent variable decelerations or bradycardia, then maybe the baby is at increased risk of fetal acidemia. So you have to prepare for delivery and reposition the mother to the left or right lateral. You can give your oxygen supplementations, your IV fluid bolus, and then scalp stimulation. Okay? But yun nga, prepare for delivery already. If you have a sinusoidal pattern, then again, it's a sign of possible increased risk of hypoxemia, then expedite delivery. Okay, so for your fetal heart rate patterns during the second stage of labor, again, decelerations are very common during the second stage of labor. So both cord and fetal head compressions could result to your early and variable deceleration. So huwag kayong matakot during the second stage of labor. Huwag niyong isi-CS yung mga pasyenteng nagkakaroon ng decelerations na nasa second stage of labor na. Okay? So other intrapartum assessment techniques, so yun yung bulk actually nung lecture natin, IPM. So other intrapartum assessment techniques, you can do your fetal scalp blood sampling. So it's intended to assess the presence and degree of fetal acidemia by analyzing fetal capillary blood. To be honest, hindi ko pa nagagawa to, even during residency, because we do not have the equipment na parang pang-ABG. So ibang machine kasi yung ginagamit nun. So what we do is that we put an amnioscope with a light source to expose the fetal scalp, which is cleansed of blood, mucus, and your amniotic fluid. And then the scalp is smeared with silicone gel so that a droplet of blood forms when the scalp is punctured with a 2mm blade. So you have to do an incision sa scalp. Medyo parang morbid. The blood is collected in long heparinized capillary tubes, and the test requires that the cervix should be at least dilated 2 to 3 centimeters, and of course, dapat ruptured bowel ka na. Okay? Because you won't be able to access the fetal scalp kung meron pang bowel. Okay, so ang goal mo lang naman is that you have your normal, it should be near greater than or equal to 7.25 yung pH, yung fetal scalp pH. So anything that is lower than 7.25, then there's an assumption that the baby is also already acidotic. Okay? But if it's less than 7.20, then you have to collect another sample immediately, and delivery is performed promptly if the low pH level is confirmed. Okay? But if it's between 7.20 and 7.25, then you can repeat the test after 30 minutes. Okay? So imagine mo, explain mo sa mother, Mami, may sugat po yung baby. Kasi, so parang medyo morbid siya. Plus yun nga, hindi siya available sa atin. Okay, so scalp stimulation, this is very, very easy to do, So you just stimulate the scalp. Usually we do this sa pag yung second stage of labor na, no? Pag kunwari umiiri si mother, tapos minsan pagod na siya, tapos stop siya umiri, mas stuck kayo, no? Tapos nagkakaroon ng bradycardia, sabihin sa'yo ng resident mo, fetal scalp stimulation, tapos ikaw, nilalaro mo lang yung head kasi nandun na siya, no? And then you, naman, pag nandun na siya, tapos gaganon-ganonin mo lang yung fetal head. Yes, fetal scalp stimulation. And then you will notice nga, acceleration of the fetal heart rate. So kasi kapag, di ba, kapag ang role nyo as a student, meron isa sa inyo taga-auscultate during kapag tinable na si mother sa delivery room, no? Nasa delivery table na siya. So one of you will do intermittent auscultation. Actually, hindi intermittent, continuous auscultation ka na pag nasa second stage of labor ka na. Tapos yung isa mong colleague, siya yung, di ba, kailangan yung mag-deliver ng baby. So pag nagkakaroon ng deceleration, sabihin niya sa'yo, fetal scalp stimulation. Stimulate talaga. Ganyan. Hanggang sa, tumaas yung fetal heart rate. Okay? You can also do your fetal pulse oximetry. No? It measures the fetal oxyhemoglobin saturation once membranes are ruptured. No? There's a pad-like sensor inserted through the cervix and positioned against the fetal face. And the use of fetal pulse oximetry significantly reduces the cesarean delivery rate for non-reassuring fetal status. But we don't have that, no? Yung fetal pulse oximetry. Nice to know. Fetal echocardiography as well, no? It uses ST analysis, no? However, it does not appear to result in meaningful improvements in pregnancy outcome. That's why hospitals do not invest on fetal echocardiography kasi hindi naman yan na-improve yung outcome. We have this before, yung STAN S31, which is a fetal heart monitor. It monitors yung ECG ng baby during labor. No? So it's STAN 31. But yun nga, according to studies, wala namang difference sa outcome when you use your echocardiography as opposed to when using your CPGs. So, mas mahal itong STAN 31. So, hospital would opt to invest on your CPG machines rather than your echocardiography. Okay? So, as a summary, you have to have proper identification and interpretation of your fetal heart rate pattern. Now, it's very crucial initial step in the evaluation of fetal well-being and intrapartum management. Okay? So, based on your 3-tier classification, category 1 is normal fetal heart rate pattern and it's not associated with fetal metabolic acidemia at the time of observation. Category 3 is abnormal pattern associated with increased risk of fetal hypoxic acidemia. Category 2, tracings are indeterminate and patients should be evaluated further for other contributing factors and should be managed accordingly. Okay? So, individualized approach is important, taking into consideration the patient's profile and clinical circumstance, and careful clinical evaluation and decision making should be made to avoid unnecessary intervention. Okay? So you do not treat the patient based on the tracing, no? But the entire clinical picture. Okay? Kasi baka naman yun nga, nagkakaroon na siya ng decelerations because fully na pala si mother, no? Hindi mo inaihi, siniyas mo na siya, yung pala, andun na yung ulo. Okay? So you could just have expedited the delivery by doing either a forceps extraction or a vacuum extraction. Okay? Any question? Tatanungin nyo naman, mayroon po ba yung exam? Mahirap yung test blueprint nyo kasi. Okay? Kaya mahirap yung exams. So sisihin nyo yung gumawa ng test.
Sino po ba nag-suggest?
Si Dean. No, because you're usually the test blueprint ninyo are higher order